Ms. Doherty, I understand that I think I failed to hear you completely. You were drawing my attention to the recommendation by counsel to the inquiry contained in paragraph 1889 and 1890. Now, I have to confess, I failed to hear the 1890. And if I can just take us to that, the proposed recommendation for the inquiry is all major healthcare construction contracts must contain provisions mandating that all the requirements for an effective planned preventive maintenance regime are in place to the entire satisfaction of the board and its water safety group and ventilation safety group before the board is required to accept handover, and NSS would endorse that. I suppose one should bear in mind that I think the ventilation safety group is a concept which is first set out in the 2022 version of SHTM 0301 and therefore wouldn't be applicable to the Glasgow contract. I think that, well, we can always go and look at the document. Right, now you were moving on to your third topic.
If I just before I do that, my Lord, if I could just clarify the National Services Division, which I'd been clarifying or correcting what's at paragraph 56 of NSS's closing statement when there was an incorrect reference to evidence, and I explained that it should have been a reference to evidence of Jonathan Best on the 19th of September. And in the written closing statement at paragraph 56, NSS seeks to clarify that the role of the National Services Division, which is NSD, and my Lord asked me more about that division. It's a division which supports the provision of specialist medical services. So it's involved in planning, commissioning and coordinating high quality medical specialist services. An example would be screening programmes. It is not responsible for capital infrastructure, for building commissioning, for environmental systems such as water or ventilation. So as set out at paragraph 56 of NSS's written closing statement, the Health Board remains responsible for ensuring that facilities and buildings are fit for purpose. And the reason that this reference was made in paragraph 56 of the written closing statement to the witness evidence was there's a suggestion in the witness evidence, well, there's a reference to NSD in the witness evidence, and that there was a concern that it might be misunderstood that National Services Division had more of an oversight of the service than I've indicated. It wasn't something that was expected in the evidence. It wasn't picked up in questions to the witness. It was just to make sure everybody's aware that National Service Division's role would not have had a different role to what I've set out. And in the context, this witness's evidence was in relation to the move of the bone marrow transplant unit. And that is a service that the National Services Division would have oversight of, but to the extent I've indicated, Lord.
Thank you.
Now moving on, Lord, to the third chapter of my submissions, which deal with points raised in other core participants' written closing statements. So turning first to the written closing statement of NHS GGC. At paragraph 10.1, NHS GGC states that relationships between its IPCT and RHI became challenging over an extended period of time, that this ought not to have occurred, and that NHS GGC has engaged in work to rebuild relationships with RHI. NSS wishes to make clear that RHI has always maintained a professional relationship with the NHS GGC IPCT. In its written closing statement at paragraphs 25 to 26, NSS referred to long-standing issues over NHS GGC's reporting of infections and to recent developments in collaborative working with NHS GGC, and NSS welcomes this collaborative approach.
A difficulty with a statement such as we find at 10.1 is that when one finds a word like challenging, one doesn't really find any content of meaning whatsoever. Do you know what is referred to as
Well, it's in NHS GGC statement.
That's
Lord.
what that is absolutely true. But you're the person in the you're the only person who I can ask the question at the moment.
Well, I think as I've said, my lord, in the written closing statement, NSS has explained problems with the reporting of infections, and that situation, I suppose, could be described as challenging, and what it required to do as a result of that, and then the recent developments. I don't have any more information, my lord, to explain why NHS GGC have chosen that particular description. Still with NHS GGC's closing statement, my lord, at paragraphs 11.6 and 16.3, they propose a recommendation for standardised reporting of incidents of infection across health boards. NSS notes that there is already standardised reporting as set out in the National Infection Prevention and Control Manual, and it's unclear to NSS exactly what further standardisation is being proposed. Comparing hospital infection rates is complex, and it is not always a robust way to improve local outcomes. Rates do not account for differences in patient risk, deprivation, staffing levels, or service complexity, making comparisons potentially misleading. Careful consideration of these caveats is essential when designing any comparison system. And NSS would urge your lordship to be cautious about making any recommendations about further standardised reporting.
Well, I wonder if, I suppose it's my fault for not exploring this further with Mr. Gray, but I wonder if there's possibility of speaking at cross purposes. As I understand it, a recommendation that Glasgow do make is about internal reporting. I think I used the word template. I don't think anyone else did. And that is what I had taken as being described by Professor Gardner. The board has adopted a more comprehensive, effective way of reporting to the health board. Now that's what I understood, and because it seemed to me that in order for me to understand that, I needed something a bit more tangible. That is why I asked Professor Gardner to provide us with a document. And I think, I'll be corrected if I'm wrong, I raised with Mr. Gray because I think he referred to it in his opening statement that I had understood that. Now, at 16.4 of the board's submission, there's reference to something else called the strengthening of national surveillance. And that's all boards report incidents electronically and through the same system. GDC supports implementation of national electronic surveillance systems. This will facilitate oversight and scrutiny of such infections nationally. With great respect to everyone, that seemed so banal or broad as not to invite challenge. Now, have I misunderstood, first of all, what GDC are recommending, and maybe secondly, what you are saying?
Well, but the NSS don't understand exactly what it is that GDC are suggesting as further standardisation. And that's the first point.
Which paragraph?
Paragraph 11.6.
Sorry, I'm
11.6, when they talk about monitoring and testing.
sorry. Have I got the right document? 11.6 of what?
Of GGC's closing statement. Oh.
We don't have an 11, at least in my text, we don't have an 11.6. And it was because I couldn't find that I went to their recommendations at 16.
Yes, we have an 11.6.
So you've got more than we've got.
Well, I can't explain that.
Okay.
But I have this is a document which is 29 pages.
Yes. Well, may be sufficient for a present purposes.
Well, I suppose, my lord, they're still saying the same thing. At 11.6, it's suggested at the end. It's the same point that I'm looking at, but I have it as 11.6, whereas on this document it's 11.5. They're suggesting that it would be appropriate to make a recommendation to standardise this reporting so that comparisons can be made across different health boards. Now it's unclear exactly what further standardisation is being proposed. That's what NSS have said to me, because there's already standardised reporting required per the manual. So what is it that they're suggesting? That's the first question. We don't understand it. And then there's also a concern that what's said there is that so comparisons can be made against different health boards. There's a concern about that, as I've explained, that there are a number of different factors which could explain different infection rates, including patient risk, deprivation, staffing levels, service complexity. So you can't just look at one health board and another like that. And that's why NSS say that your lordship should be cautious about making any recommendation about further standardised reporting. First of all, we don't know what they mean. And secondly, why they seem to want to do this to look at comparisons, and NSS say it's not as easy as that.
Well, I think, first of all, I have to apologise for introducing the internal reporting point, because I was looking at the wrong part of the Glasgow statement. So we can leave that aside. Perhaps for present purposes, I can listen to your point that insofar as GGC are making a recommendation or suggesting a recommendation the inquiry might make, it is not sufficiently precise for at least NSS to understand. And I have to say it's not sufficiently precise for me to understand either. And this reflects the high level at which GGC have chosen to communicate. Right. Maybe we can't take it anymore.
No, so paragraph 11.6, but it seems to be 11.5 in the document that was on screen. That's what they're suggesting, and then they follow that through into their proposed recommendation at 16.3. So that's what for the reasons you've said, my lord, we don't understand what they're asking for, and we say it's not as easy as that. You don't just compare infection rates at health boards, which is what they seem to suggest would be useful. Now, at 16.4, they support a national electronic surveillance system for healthcare-acquired infections with all data, that's the way they word it, with all data on infections flowing to RHI. Now, NSS welcomes this support for a national electronic surveillance system, save for a concern about GGC's reference to all data going to RHI. NSS say it may not be appropriate for all laboratory data to go to RHI, and the exact scope of the data to be included is a matter requiring further consideration when the system is established. NSS has said more about the proposed electronic surveillance system in its own written closing statement at paragraph 54, Lord. Now, moving on to the written closing statements by the Scottish Government. At paragraph 35, in relation to infection reporting, the Scottish Government notes that the proposed recommendation...
Give me just Lord. A moment, Mr. Kirby. No, paragraph 35.
Paragraph 35. They refer to the proposed recommendation that NSS report to the chair of the health board if there's a failure to comply with reporting. That's the proposed recommendation at paragraph 1892 of Council to Inquiry's closing statement, and the Scottish Government notes that this might be inimical to NSS's expressly supportive role, and it suggests that a better way might be to escalate within the board by, for example, a director's letter, a DL, or a letter from the Cabinet Secretary, rather than conferring a power on NSS to report, that power being by legislation. NSS supports the approach proposed by the Scottish Government in this connection. Now, turning to the submissions of Dr. Peters, Redding and Inkster. Lord, do you want me to wait while you get those before you?
That would be very kind of you. I've now got it.
Thank you. At paragraph 133,
yes.
Paragraph 133, the doctors endorse Tom Makin's recommendation that routine testing for pseudomonas should be added to the SHTM. And we note that Counsel to the Inquiry has recently indicated his agreement with an adoption of this recommendation. NSS's position is that the approach in Scotland and England about testing for pseudomonas is substantively the same, although there are some differences in how the approach is worded in the current guidance. In England, predominantly, there is monitoring in high-risk areas only, and this is consistent with the approach in Scotland. And in any event, as part of the work ongoing in relation to SHTM 0401 and the English equivalent, language is being aligned across the devolved administrations. NSS considers that a much fuller analysis of the merits of extending routine pseudomonas testing beyond high-risk areas should be undertaken before any recommendation is made by the inquiry. Now, the next paragraph I'd like to look at in these submissions is paragraph 134, which considers the role of the authorising engineer, and the doctors ask the inquiry to consider making recommendations to improve the effectiveness of this role in the future. NSS would like to assure, my Lord, that SHTM 00, which is Healthcare Engineering Policies and Principles of Best Practice Guidance, is being updated in 2026 to 2027, and the intention is to further clarify the role of the authorising engineer. NSS would be cautious about any recommendation being made without adequate review and input from experts. For example, it has encountered situations where the expansion of the authorising engineer's role has made the role of other parties more ambiguous, which has led to gaps in decision making. Now, paragraphs 136 and 137 of the doctor's submissions suggest that the inquiry should consider whether the SHTM 0401 provisions regarding water safety risk assessments can be improved and or more effectively enforced. It's difficult for NSS to comment without knowing what the new provisions would be, and it would again be cautious about any recommendation being made without adequate review and input from experts. At paragraph 137, there's mention of effective enforcement, and NSS note it would not be appropriate for NSS to have an enforcement role in relation to risk assessments. NSS also notes that recommendations regarding water risk assessments could cover matters dealt with in British standards, which the SHTM and the HTM are derived from. And examples of British standards where this might be an issue include BS 8580 Part 1.
Sorry, could you give me that?
BS 8580 Part 1 which deals with water quality, risk assessments for Legionella control, code of practice, and also BS 8580 Part 2, which is entitled Water Quality, Risk Assessments for Pseudomonas and Other Waterborne Pathogens, Code of Practice. If Lord's happy, I'll move on to paragraph 144. There's reference in these submissions to the Rectification Board and proposing that the Rectification Board should be supervised by RHI and NHS Scotland Assure. NSS doesn't know what body is being referred to by the term Rectification Board, and in any event, it would not be appropriate for NSS to have a supervisory role. NSS operates and is effective in a supportive role. Finally, my Lord, I turn to the submissions on behalf of the written submissions on behalf of IBI. Again, if my Lord wants to have them available. And it's first paragraph is 11.12.
Yes, I've got there.
You've got that, Lord. Well, paragraph 11.12, IBI refers to NHS England's NHS Estates Technical Bulletin, number 2024/3, and it invites the inquiry to acknowledge the updated technical requirements mandated in England with a view to those requirements being implemented in Scotland. NSS urges caution here. This NHS Estates Technical Bulletin has led to some concerns across stakeholder groups since its publication. NSS is currently in discussions with colleagues in the devolved nations around how these concerns can be addressed. The current intention is to move to a harmonised SHTM 0401 and an equivalent HTM 0401 suite of documents across England, Wales, Scotland and Northern Ireland. And that would see key themes from the NHS Estates Technical Bulletin absorbed, where appropriate, into a single place of truth, namely the updated SHTM 0401 and HTM 0401 documents. And a UK-wide consultation on this document is underway, with plans for a 2026 publication.
Now, I don't think we've really heard anything about the technical bulletin series. Is there a Scottish equivalent to that sort of document?
I don't know.
Or
is
we
the
don't
answer.
know,
I don't
right.
know, my lord. I'm sorry.
The project for moving towards a uniform, now is it a document or series of documents?
They described it as a suite of documents.
Suite of documents.
Yes. That would absorb themes from this NHS Estates Technical Bulletin where appropriate.
Right.
That's how it's been described.
And this is something different from the technical memoranda.
I understand so, my lord.
Right. Okay. Maybe the key point is that this is currently under consideration.
It is, and there's a UK-wide consultation, and with plans for a 2026 publication. And finally, my lord, IBI at paragraph 11.13, IBI refers to the principles of the golden thread of fire and safety design introduced under the Building Safety Act 2022. And yesterday, Council to the Inquiry suggested that if other core participants think this reference is helpful, they should say so. And Your Lordship yesterday indicated that you'd welcome assistance on this point. NSS fully supports the concept of the golden thread. In fact, NSS's witness Thomas Roger referred to this concept in his witness statement for the Edinburgh 3 hearings, which commenced on the 26th of April 2024. His witness statement is in volume 1 of the witness statements for those hearings, document 17, page 444, and at paragraph 37, he refers to and quotes this golden thread principle. If NSS does have further comments which it considers may assist, my lord, then its intention would be to submit them in writing in early course. My lord, that's the end of my submissions unless there's anything else I can help with.
Thank you very much, Ms. Docherty.
Thank you.
Good afternoon, Ms. Crawford. You are appearing for Scottish ministers.
Indeed, yes, my lord, and thank you. I should, of course, at the outset express the gratitude on behalf of the ministers to the inquiry for the opportunity to make these oral submissions on their behalf. And in that regard, I adopt the closing statement already submitted to the inquiry following Glasgow 4 session. The inquiry has, of course, received and heard a very large amount of evidence in order to inform itself and to fulfil the terms of reference. It perhaps goes without saying, but is worth emphasising, that a number of critically important issues have been raised, both in relation to the Queen Elizabeth University Hospital, but also the Edinburgh Royal Infirmary project. And recognising those critically important issues, of course, the ministers established this inquiry and have participated with it. But it is obviously for the inquiry and only the inquiry to assess the evidence and thereafter address and fulfil the terms of reference. And in that regard, the ministers repeat their gratitude to the chair, to counsel to the inquiry, and to all other members of the inquiry team for their undoubted hard work and diligence. Recognising and respecting the proper role of the inquiry the submissions for the ministers will be at a high level, or perhaps also described as at a strategic level. Before I turn to address those high-level issues, I should, again echoing what is said in paragraph 1 of the closing statement, frame those submissions with the following remarks. And in my submission, they are important remarks. First of all, the ministers pay tribute to all the patients, their families, and all staff affected by the issues which arose at the Queen Elizabeth University Hospital, and to thank them for reliving those events in this inquiry and for their insight and assistance. And just pausing there, my Lord, as with other core participants, no one could fail to be moved by the at times harrowing testimony provided by some of the witnesses to this inquiry. And it's again important to acknowledge that. Secondly, the ministers continue, by way of opening remarks, continue to be committed to provide patients with the best possible patient-centred healthcare. I will have more to say on that very shortly. But for present purposes, it is to be noted that the ministers are, of course, collectively responsible and accountable to ensure that patient-centred healthcare is delivered by NHS Scotland to the highest possible standard. Turning, if I may, to look at the responsibilities of the ministers and indeed how it is that they deliver patient-centred healthcare in Scotland, it may assist, my Lord, if perhaps repeating myself from the closing statement I made in the Edinburgh session, to remind my Lord of some provisions of the National Health Service Scotland Act of 1978. And with apologies for adding to my Lord's paper, I have had printed off a few sections of that Act and indeed of other statutes, which hopefully will save the writing. The first provision in the bundle is Section 1 of the 1978 Act, which provides for the general duty of the Secretary of State, now of course the ministers, to promote in Scotland a comprehensive and integrated health service designed to secure A, improvement in the physical and mental health of the people of Scotland, and B, the prevention, diagnosis and treatment of illness. And for that purpose, to provide or secure the effective provision of services in accordance with the provisions of the Act. Reading on in the bundle, that provision or securing that provision is achieved by the establishment of health boards, which we see in Section 2. Subsection 1, the Secretary of State shall by order constitute in accordance with Part 1 of Schedule 1 boards for such areas as he may by order determine for the purpose of exercising such of his functions relating to the health service as he may so determine, etc. And these bodies will be called health boards. And then there's provision for special health boards, which I needn't trouble my Lord with for present purposes. And reading on in the bundle, it's about 3 or 4 pages on, we then come to Section 2A, which makes provision for the duty of a health board. Section 2A, subsection 1. It is the duty of every health board and special health board and of his Health Improvement Scotland and the agency, the Common Services Agency, and I'll come to those, to his and the agency in a moment. It is the duty of those organisations to promote the improvement of the physical and mental health of the people of Scotland. Subsection 2 is an enabling power to do that which is likely to assist in discharging the duty. And then turning over a couple of pages, we come to section 2C, which sets out the functions of health boards. QC subsection 1, every health board must, to the extent that they consider necessary to meet all reasonable requirements, provide or secure the provision of primary medical services as respects their area. And they may also do so as respects the area of another health board. And subsection 2, for the purpose of securing the provision of primary medical services under subsection 1, a health board may make such arrangements for the provision of the services as they think fit. And then reading on, if I may, to section 10, which addresses the Common Services Agency. Now NSS, well, currently known as NSS Scotland, but section 10, subsection 1, there shall be constituted a body to be called the Common Services Agency for the Scottish Health Service, hereinafter referred to as the agency. And my Lord will note its functions are at subsection 1, capital A. Schedule 5 is, needn't trouble my Lord with, but that's just the composition of the agency. Subsection 3, the Secretary of State may by order delegate to the agency such of his functions relating to the health service as he considers appropriate. And my Lord has heard a lot of evidence relative to NSS Scotland and what it does. And there are a number of further detailed provisions, again, by way of delegation at subsection 4, subsection 6 over the page. The agency shall provide such services and carry out such tasks for bodies associated with the health service as the Secretary of State and those bodies may agree. And the agency shall act subject to in accordance with directions as may be given by the Secretary of State at subsection 7. Then we turn, if we may, to section 10, capital A, and the creation of the body Healthcare Improvement Scotland. There is established a body to be known as Healthcare Improvement Scotland, in this Act referred to as HIS or HIS, which A is to exercise the functions conferred on it by virtue of this Act and any other enactment, including the 2021 Act. And B has the general duty of furthering improvement in the quality of healthcare and of services provided under the 2021 Act. And there's a definition of healthcare in subsection 2, means services for or in connection with the prevention, diagnosis or treatment of illness provided under the health service, or B by persons providing independent healthcare services. Subsection 3, HIS is to act subject to and in accordance with directions as may be given by the ministers. Section 10C makes provision for health service functions to be exercised by HIS. Subsection 1, HIS is to exercise the following functions of the Scottish ministers. A, functions in relation to supporting, ensuring and monitoring the quality of healthcare. My Lord may recollect Ms Docherty mentioning a moment or two ago the use of the word support, which has an echo in section 10C. To supporting, ensuring and monitoring the quality of healthcare provided or secured by the health service, including, without prejudice to the foregoing generality, providing quality assurance and accreditation. B, functions in relation to supporting, ensuring and monitoring the discharge of the duty under section 2B, which we looked at a moment or two ago. Sorry, we haven't looked at section 2B, but each body to whom that section applies. Section 2B is a provision about involving the public in relation to the provision of healthcare services. And C makes reference to section 2D, capital D, which is an equal opportunities duty. If I may invite my Lord to turn over the page. These list a number of functions which HIS is to perform. And my Lord can read these for himself, but I might invite my Lord just to read with me subsection D, which provides that HIS is to have the function of the duties of the ministers under section 47 of the Act, which is to make available such facilities as appear to HIS to be reasonably required for undergraduate and postgraduate clinical teaching and research, and for the education and training of persons providing or intending to provide services under this Act. Just pausing there, my Lord will recollect we've had some evidence about the provision of education and training, not least in relation to infection prevention and control, and with apologies for the management speak, mention of workforce strategies being developed in relation to that particular discipline. And we also invite my Lord...
Just so I'm picking you up correctly, workforce strategies, and I don't mean to trivialize this when I say mechanisms for people working better together and...
No, I was actually meaning
relating.
more.
Or is this something else?
No, I was actually meaning this is the provision of proper training. I don't mean to proper. It's the provision of education for healthcare professionals, which will include, for example, IPC. And I think we heard evidence, I think from Professor McMahon in the Edinburgh session, for example, relative to ongoing work in relation to, I think it was IPC nurses particularly he was talking about. So that was what I was meaning by...
All right,
workforce.
okay, my fault entirely,
No.
I hadn't followed
No.
you. Yes, I now recollect Professor McMahon's evidence about, as I understood it, an initiative to apply further resource to IPC.
Indeed. And the point I'm making, my Lord, is just to set the framework, statutory framework under which the delivery of healthcare is provided in Scotland, and here we have specific provision relative to education. And obviously there's a lot of detail underneath all that.
Mm-hmm.
And then section 2, capital A, HIS is to exercise, little a duty of supporting, ensuring and monitoring the quality of services provided by the health boards. Reading short, including quality assurance and accreditation. And similar provision in relation to the duties under 2B and 2D. And over the page at subsection 3, if I may, there is provision for HIS at little c, whereby HIS, if requested by the ministers, has a duty to provide them with advice relevant to the health service functions of HIS. A function and a power to provide such advice to ministers at any time. And also at little e, general advice provisions, including to health boards. And my Lord will know that at times GGC requested advice from HIS. And then at little f, there is a general power to disseminate HIS considers relevant of general or specific application arising out of and connection with the exercise of its health service functions. That provision again may be relevant to at least one of the terms of reference in relation to information sharing. There is provision in the Act for dissemination by HIS. Moving forward in the bundle, if I may, so about 3 or 4 pages on, we come to section 10Z14, And I simply highlight this provision to, again, provide this inquiry with information about the monitoring, supervision, delivery of healthcare services in Scotland. So we have in 10Z14, for the purposes of its functions as they relate to the provision of independent healthcare services, a health board must take into account the matters mentioned in subsection 3. And those matters include, in subsection 3, reports prepared, etc., by HIS. So that's a dissemination provision, again, in relation to independent healthcare services.
I think I've forgotten if I ever knew what an independent healthcare service is. I think I'd rather assume it's out with the NHS, but I may be wrong about that.
There is a definition, my lord. I may have to come back to my lord on that, because otherwise I'm going to have to crawl through
I mean,
a very lengthy
it will
statute.
be defined somewhere. Right?
It is.
And
It's not in the interpretation section. It's probably section 1 or section. It is somewhere, my lord. My lord, would permit me.
I can find it.
Yeah. My lord, if I could then invite my lord, perhaps moving forward to 2 pages in the off-print to section 12H. My lord will note that it's the duty of each health board and of the agency to put and keep in place arrangements for the purpose of monitoring and improving the quality of healthcare which it provides to individuals. Then a couple of pages on section 12I. Headed up, a duty in relation to governance of staff. It shall be the duty of every health board and the agency to put and keep in place arrangements for the purposes of A, improving the management of the officers employed by it, B, monitoring such management, and C, workforce planning. Simply draw that provision to my lord's attention because it may be of some relevance to whether there is in existence provision to enable, to use the words of this section, governance of the healthcare staff employed by the health board. Then in section 12J, there is a duty to cooperate between health boards. And also in section 13, a few pages on, a duty between health boards, local authorities, and education authorities to cooperate with one another to secure and advance the health of the people of Scotland. How that operates in practice, my lord may recollect, was explained by Miss Freeman, the former Cabinet Secretary, in her statement for Glasgow 4, dated 10th October 2025, at paragraph 6, which in turn cross-referred to her statement for Edinburgh, dated 18th December 2023. And the relevant paragraphs in the December 23 statement are paragraphs 9 through to 26.
My fault. I've got the Edinburgh reference. The reference to the Glasgow statement.
Paragraph 6, and my lord might also want to look at paragraphs 8 through to 15.
Right. And Ms. Freeman has just provided one witness statement in relation to Glasgow.
4, yes.
What?
Yes.
Right. Yep.
And I've been helpfully told by those sitting behind me that insofar as independent healthcare service is concerned, my Lord will find the definition in section 10, capital F.
Electronic communication is
Sometimes good, sometimes bad.
useful.
Yes, indeed. I was aware when I heard something happening that somebody might be giving me the answer to my Lord's question, and I'm grateful.
So it's defined in section 10.
10 capital F.
10 capital
F. F
Thank
for Freddie.
Right. Thank you.
Turning to the operation of the respective powers and functions of the ministers and how they deliver healthcare in Scotland through health boards, my Lord may also derive assistance from the statement of Mr. Wright, both his Edinburgh statement of 15th March 2024 and the paragraphs which address this matter are paragraphs 15, 16, 20, 25, 79 through to 84, 84, and 101 to 103. And he provided similar evidence in his statement to Glasgow 4, that statement being dated 26 September 2025, at paragraphs 4 to 6, 24, 58, 71, and 72. Picking up, if I may, on Mr. Wright's evidence and also the closing statement of the ministers at paragraph 6 and the question of who is responsible for the employment of the workforce in NHS Scotland. And paragraph 6, my Lord may recollect, refers to section 28 of the Inquiries Act and the constraint on my Lord relative to what are described as Scottish matters.
Yes, I would particularly value your guidance on that.
Thank you, my Lord. Well, again, if my Lord goes back to his bundle of offprints of statutes, in the first tab, and just going back again to what the quick excursion through the 1978 Act, we saw from that it is the health boards who are delegated the function of employing staff sufficient to deliver healthcare in their respective health board areas. Turning, if I may, to the Scotland Act and section 51. Section 51 is headed up the civil service. The Scottish ministers may appoint persons to be members of the staff of the Scottish administration. And subsection 2, reading short, provides that that service shall be service in the civil service of the state. Now, the point I make from section 51, my Lord, is that the only power the ministers have to employ people is through section 51. And those people, in the language of 51 subsection 1, are members of the staff of the Scottish administration, commonly known, as we see in subsection 2, civil servants. They do not have a power to employ staff in the NHS. payment of the members of the Scottish of the staff of the Scottish administration is from the Scottish Consolidated Fund. My Lord sees that from section 51, subsection 8. And my Lord will find a bit more information about the Scottish Consolidated Fund in section 64, which is over the page. Subsection 1, there shall be a Scottish Consolidated Fund, and the Secretary of State, i.e. the UK Government, shall from time to time make payments into the fund out of money provided by Parliament, that's the UK Parliament, of such amounts as he may determine. That takes me on to reserved matters, if I may. And a page or two on into the bundle, my Lord will find first of all an off-print from Schedule 5. Reserved matters, and paragraph 8 is in part 1 of Schedule 5, which relates to the heading of that. I should have provided for my Lord. The heading of that is General Reservations. And paragraph 8 provides subparagraph 1 that the civil service of the state is a reserved matter. And my Lord will recollect from section 51 that members of staff of the Scottish administration are civil servants of the state, paid out of the Scottish Consolidated Fund. The short submission made on behalf of the ministers, my Lord, is that there is no power for them to employ anyone in the health service. If there were to be power, that would obviously require legislation by the UK Parliament. Yeah. Thank you. So if we look to members to chief executives and the like of health boards, as my Lord knows from Mr. Wright's evidence, they are employed by health boards and may be dismissed by health boards. And the ministers may, as Mr. Wright said, make noises if they are dissatisfied with the performance of the chief executive. But ultimately, the ministers cannot dismiss a chief executive or indeed any other member of staff of the NHS in Scotland. They can, the ministers being they, can remove accountable officer status from a chief executive, which no doubt, I say no doubt, I strongly suspect would have consequences for that person's ongoing employment by the health board. And Mr. Wright provides an explanation of that in his statement of September 2025 in more detail. Moving, if I may, my Lord, to more specific reserved matters, which are to be found in Part 2 of Schedule 5. The first one, which may be of relevance to Scottish matters in terms of the Inquiries Act, is that provided by G2, headed up health professions. the regulation of the health professions is a reserved matter, with an exception relative inter alia to Section 21 of the 1978 Act and suitable experience for medical practitioners. And my Lord will note the number of professions who are encapsulated by the phrase health professions. I don't think I need to read those out. But they encompass more or less every health profession you could conceive. The next reserved matter, which may be of some relevance, is the auditor, and that's in G3, and that may be of some relevance to general auditing of the health service. And finally, my Lord may also pause to note that there are certain provisions which may not be directly relevant, but I thought for completeness, my Lord should have it, H3 and job search and support. So actually, my Lord has H3, my Lord should have had H2. And I'm sorry, my Lord doesn't have it, but I can read out H2, which is headed Health and Safety. And it comprises the subject matter of Part 1 of the Health and Safety at Work Act of 1974. And the Health and Safety Commission, the Health and Safety Executive, and the Employment Medical Advisory Service. So rather than H3, it was H2, my Lord. I'm not failing as mine and printing off the wrong reserved matter. But again, that may be relevant to any recommendations which my Lord considers appropriate, just to flag up that health and safety is also a reserved matter.
And that might have most obvious reference to the matters that are picked up by SHTM 0401.
It may do as well, which maybe, well, my Lord has heard the reference to NSS Assure working with and collaborating with their English colleagues as well.
Mm-hmm.
But again, one would have to drill down, with apologies, my Lord, I haven't drilled down to look exactly what Part 1 of the Health and Safety at Work Act says, nor indeed looked at the remit of the Health and Safety Commission, the Health and Safety Executive, or indeed the Employment Medical Advisory Service. I don't drill down into detail. And again, it'd be a bit difficult to do that in the abstract, not knowing precisely what might be envisaged or be thought of by my Lord eventually. But simply to draw that to my Lord's attention, if I may. My Lord, having again addressed the functions and duties of the ministers and of the health boards, having looked at Scottish matters / reserved matters under the Inquiries Act, I now move on, if I may, to say a word or two about the ministers' oversight of health boards. And at this stage, before my Lord puts his bundle of legislation to one side, if I could invite my Lord to return to that and look at tab 2, which contains the 1978 Act. And working from the back of that, it might be easier. About 5 pages, 6 pages from the back, my Lord will first find section 77. Which makes provision for the heading default powers, where the Secretary of State is of the opinion on representations made to him or otherwise that, reading short, any health board have failed to carry out any functions conferred or imposed on them by or under this Act, or have in carrying out those functions failed to comply with any regulations, schemes, proposals or directions relating to those functions, he may, after holding an inquiry, make an order declaring them to be in default. When such an order is made, the members of the body shall forthwith vacate their office. Now, obviously, my Lord, I've drawn my Lord's attention to the reserved matter into Section 51 of the Scotland Act. But my Lord will note that rather than a dismissal power, there is, following an inquiry and an order being made, there is a requirement of the members of the relevant body to vacate their office. Again, I draw that provision to my Lord's attention just so my Lord has, hopefully, as complete a picture about how it is that the ministers ensure oversight of the health boards to whom healthcare provision has been delegated. There are further powers, first of all in Section 78, emergency powers as they're described. If the Secretary of State is of the opinion that an emergency exists and thinks it necessary in order to secure the effective continuance of any service under this Act, he shall have power to direct that any function conferred by or under this Act on any body or person shall, during the period of the emergency, be performed by such other body or person as he may specify in the direction. And over the page, Section 78, capital A, makes provision in case of service failure. Subsection 1. This section applies where A, it is a function of a body or person under or by virtue of this Act to provide or secure the provision of a service, and B, the ministers consider that the body or person has failed, is failing, or is likely to fail to provide the service, or to provide it to a standard which they regard as acceptable. Subsection 2, the Scottish ministers may, where they consider it necessary for the purpose of ensuring the provision of the service in question to a standard which they regard as acceptable, direct that specified functions of the body or person, under or by virtue of this Act, be performed for a specified period and to a specified extent by A, a body falling within subsection 4, or one or more persons falling within subsection 5. The bodies are listed in subsection 4, and the persons in subsection 5. And my Lord may pause to note that the persons, A, can be an employee of a health board, and B, a member of the staff of the Scottish administration. So in case of service failure, there is a provision within Section 78A for a member of the staff of the Scottish administration, a civil servant, to perform such functions as the ministers may direct. Now, those provisions to which I've drawn my Lord's attention are reflected to a certain extent by the escalation framework, which my Lord may recall seeing, and in particular by level 5. As Mr. Wright explained in paragraph 29 of his 26 September 2025 statement, and I just quote him here, stage 5 escalation would only be used in the most exceptional circumstances when the Scottish ministers are of the view that a health board as a whole requires direct statutory intervention because of the view that the board are unable to deliver safe and effective health care. And he then quotes from level 5 itself in the escalation framework, which is to the following effect: the level of risk and organisational dysfunction is so significant that the NHS board requires direct intervention using statutory powers of direction. Those statutory powers of direction are found in Section 78A. Now, it is of course a matter for the inquiry, but in my submission, I would suggest to the inquiry that the powers to which I've just made reference do provide a proper and appropriate mechanism for intervention if the circumstances require that, for the proper provision of patient-centred healthcare in Scotland. And I respectfully submit to the inquiry that no further statutory or regulatory mechanism is required for intervention in the event of service failure. Of course, the ministers are and will continue to be accountable to Parliament and to the people of Scotland for the exercise, or indeed the non-exercise, of those intervention powers. But the mechanism is already in place for intervention.
And the context of what you're directing me to at present, Ms. Crawford, is counsel to the inquiry's submissions in relation to sufficiency of powers of intervention.
Indeed.
Yeah.
Indeed. A related point arises relative to the manner in which health boards deliver their functions, or should deliver their functions, as set up by the Scottish ministers. And there are a number of mechanisms and indeed oversight. For present purposes, it perhaps suffices to note, again, under reference to the closing statement to this session of the inquiry, paragraph 17 to 19, the reference to the blueprint for governance, and also at paragraph 13, the reference to the director's letter of 2024/08, paragraph 21, and the framework document. Detailed documents setting out how the ministers require health boards to deliver the functions delegated to them to provide patient-centred healthcare in Scotland.
I got your reference to paragraph 17 to 19. I think you mentioned another paragraph.
Paragraph 21, I'm sorry, my lord.
No, it's my fault.
Where hopefully if I just check the reference, so I'm not misdirecting, my lord. Yes, paragraph 21 refers to the director's letter, which the inquiry kindly gave us leave to lodge, and reference to the framework document. And it may bear some reading, indicating the manner in which health boards and ministers are to deliver their respective functions, and reinforcing the need to comply with the blueprint for good governance. While I remember, my lord, as a point of detail, I think this arose in submissions for counsel to the inquiry yesterday morning. The first edition of the blueprint for governance was January 2019.
I misremembered.
And the second edition was 23rd December 2022. And one can also, in relation to this question of expectations, recall the oversight, the supervision delegated to HIS, to which I made reference when looking at the provisions of the 1978 Act. The submission here, my lord, is that, again, we can see in practice that there are proper checks to ensure that health boards do deliver that which they are required to do under the 1978 Act. And in terms of delivery and effectiveness of delivery and checks and balances of health boards, one can perhaps note how that operated, and learning lessons indeed, the events, how that operated by reference to the events for the Edinburgh Royal Infirmary. My Lord may recollect that as soon as the problem was discovered by the senior executive team, immediate steps were taken to inform the ministers, firstly through the Director General, and immediately escalated up to the Cabinet Secretary, and that the ministers very, very quickly intervened to suspend the opening of the relevant department. So again, that's an example I would suggest to my Lord.
Sorry, it's again, I have to apologise. The instance take me back to the beginning of the instance. Yes, you're referring me to.
I was saying that when one looks to the escalation framework and the Section 78A powers and the oversight and checks and balances, and if one's following the blueprint for governance appropriately or its predecessor, one can see that operating in practice by the Edinburgh Royal Infirmary and the events which led to the Cabinet Secretary, yes, the ministers deciding that the opening should be delayed. The submission I'm trying to make to my Lord, perhaps inelegantly,
not at all,
is that there are processes, proper processes in place which do enable prompt and effective action to be taken if something has gone wrong.
Within a matter of days.
Within a matter of days,
that.
Yes. Now, of course, mistakes will happen, but there is the point I make, my Lord, is that there is a mechanism in place. And what that leads me to submit to my Lord is that those checks and balances mechanisms, and indeed there are others to which I'll come to in a moment or two, are, I would respectfully submit to this an inquiry, an appropriate way to secure provision of healthcare, rather than an overly centralised system run and managed operationally by the ministers. And I remember having a discussion with my Lord in the Edinburgh closing submission session relative to that if the inquiry, my Lord, comes to the view that there should be more hands-on operational control on the part of the ministers, that would raise a number of complex issues touching, and indeed not just touching, grabbing perhaps, issues of a highly sensitive political nature, which would require to be addressed by the Parliament, Scottish Parliament, but would also require, I would suggest, prior to that, a detailed consultation exercise across Scotland on the topic of how the delivery of healthcare in Scotland is best managed. I note in the submissions for counsel to the inquiry an acknowledgement that some of their suggested recommendations will increase the resource burden, both on health boards and also on the ministers and on agencies. So far as resource is concerned, allocation of resource, by which I mean financial resource, is, I would respectfully submit, the paradigm of a political decision exercised by the Scottish Parliament through its approval of the budget each year. and that allocation of financial resource, budget allocation, is carried out by the Parliament in the public interest. So the submission I make, my Lord, is while of course the inquiry can make recommendations which may be resource intensive, allocation of budget to meet those intense resource requirements will ultimately be a matter for Parliament. And I say that with all due respect, of course, to the inquiry.
The inquiry can only recommend.
Indeed, indeed. My Lord, I wonder if I might make a few further general observations, and this really relates to how the ministers deliver or seek through delegation to health boards delivery of healthcare in Scotland. There is, my Lord may come across this, the World Health Organization Global Patient Safety Action Plan of 21 to 2030. It should be noted that Scotland is not recognised as an independent member of the World Health Organization. However, the ministers take full account of the principles set out in that Global Patient Safety Action Plan. And a reflection of that might be found in the document noted at paragraph 2 of the minister's closing statement, namely the NHS Scotland Healthcare Quality Strategy and the 3 quality parameters set out in that. In terms of reducing avoidable harm in healthcare and strengthening patient safety, which is the overarching theme of the Global Patient Safety Action Plan, that is delivered, I've made reference to the quality strategy, but one can add to that at either general or granular detail, depending upon which particular programme is being discussed. But there are a number of national improvement programmes, clinical governance arrangements, HIS itself, the Scottish Patient Safety Programme, the duty of candour, to which I'll come in a moment or two and say a few more words about that, a systematic adverse event review process.
I wonder if you should give me these.
In writing, I can do, my Lord.
At dictation.
Oh, dictation space, right.
Or either at dictation.
No, I'll give it at dictation speed. I'm not sure how far my Lord got when he was trying to catch up.
Not very far.
Right. National improvement programmes.
Yes.
Clinical governance arrangements. And that's primarily a reference to the blueprint for governance. HIS. The Scottish Patient Safety Programme. Duty of candour. And I will come back and address that in a bit more detail, if I may.
Maybe just to give me a heads up, as expressed in statute or?
As expressed in statute, but there are also...
Okay, I think you've given me the heads up.
Hey, thank
statute
you,
plus.
Plus, yes. Adverse event review processes. Health and social care standards. education and training of the healthcare workforce, and the body known as NHS Education for Scotland. And infection and prevention control measures. And again, I'll have something to say about that in a moment or two. Now, I'm aware, my Lord, I've given very general headings here, but it's just to present a general view, overall view about how it is through these various programmes and arrangements that the ministers ensure or have the ability to ensure that patient-centred healthcare is delivered to the highest standards possible. And proper account is taken of the principles set out in the WHO document. My Lord, I mentioned IPC, Infection Prevention Control, a moment ago. My Lord may care to note, and this may be of some relevant to submissions about the IPCT workforce, that there is or has been established by the ministers an Infection Prevention Services Workforce Strategic Plan, and this goes back to a point I was making earlier, my Lord, which is focused on health boards identifying and reviewing the current specialist IPC roles.
This again is a reference to the work that Professor McMahon referred to.
Indeed,
Yeah.
indeed. And again, I think reflecting back on what Professor McMahon said, my Lord may also recollect his evidence to the effect, I'm summarising at a very general level, that some recommendations were being made in respect of training and education for the IPC workforce. I should advise, my Lord, that that workforce strategic plan will be reviewed this year, and further consideration will be given at that time about the continuing recruitment and training needs for the IPC workforce. My Lord, I now, if I may make a few submissions in relation to, and I mean no disrespect, but just by way of a useful shorthand for my purposes, make a few submissions relative to whistleblowers. As I say, I mean no disrespect to the relevant doctors when using that collective term. So far as the communication by them in their evidence are concerned, the ministers regard those as disclosures which would be protected under the Public Interest Disclosure Act of 1998. They, in the minister's submission, should also be regarded as disclosures protected under the NHS Scotland PIN whistleblower policy of 2011.
NHS
Scotland PIN whistleblowing policy of 2011. And that policy, my Lord...
That's a national policy.
It's a national policy, yes, my Lord. And I can summarise it to this effect. It requires health boards to ensure staff can safely raise concerns about risk, malpractice or wrongdoing, and to investigate, act, and provide feedback. And that policy also enables concerns can be raised outside the relevant health board, where the internal whistleblowing processes have proved to be ineffective or unsafe. It follows in the Minister's submission that the whistleblowers were and are fully entitled to raise the concerns that they did. And I venture to suggest we're, I suspect, under a professional obligation to do so anyhow.
And you make that submission under reference to the specific evidence that we've heard, as opposed to just general principle?
The specific evidence we've heard, yes, my lord. If I may now, having flagged it up a moment or two ago, turn to look at the duty of candour. And with apologies, invite my lord to return to his folder of papers. The duty of candour, the statutory duty of candour, arises under the Health, Tobacco, Nicotine, etc. and Care Scotland Act of 2016.
Before we do that, just really
Sorry,
for
my
my assistance, the Public Service Disclosure Act of 1998, am I remembering correctly? It sort of fits within the employment
Indeed it does.
legislation, and it gives protective status to those persons. It's not at all specific to healthcare.
It's not.
Who raise concerns. And the point you were making was that in terms of that act, which has consequences within the general structure of employment law, that the three doctors would have the status of protected. I think the term is
protected disclosure, indeed.
Yeah.
But that's built on, as I mentioned, by reference to the policy, which
yes.
requires or enables, should enable staff to be able to report their concerns. But the root of that, I suspect, is in the 1998 Act.
Duty of candour.
Duty of candour, yes, I'm obliged, my lord. The section which I printed from the Health, Tobacco, Nicotine, etc. and Care Scotland Act of 2016 is section 24. And my purpose in drawing that to my lord's attention is again to inform my lord, hopefully, of an ability, a statutory mechanism by which the monitoring of the compliance with the duty of candour is or should be carried out. And my lord can see in section 24 that a responsible person who provides a health service, reading short, must prepare an annual report on the duty of candour as soon as reasonably practicable after the end of that financial year. Subsection 2 sets out what that report must provide. Subsection 3 indicates, obviously, that there should not be any identification of any individual. Subsection 5, the responsible person is to notify HIS the ministers and the Social Care and Social Work Improvement Scotland relative to care service or social work service. A person, subsection 6, a person mentioned in subsection 7 may, for the purposes of monitoring compliance with the provisions of this part, serve a notice on a responsible person, requiring the responsible person to provide the person serving the notice with information about any matter mentioned in subsection 2, and that information to be provided within the time specified in the notice. And those persons are set out in subsection 7, including HIS and the Scottish ministers. And then there's provision in subsection 8 for the ministers and HIS, whereby they may publish a report on compliance. So the point I'm seeking to make here by reference to the duty of candour, my lord, is to say that there is built into the Act itself a mechanism to require reporting and to check that the duty of candour as set out in the Act is being properly complied with. I should add, for the sake of completion, that to date, the ministers have not exercised its power under subsection 8 of section 24, but that power does exist in the legislation, reflecting my theme that there are mechanisms, processes to enable checks to be made if necessary. If I may, my lord, and I propose to say a few words about NSS Assure, as I will still call them, which in my submission is a body which provides a further check across a number of areas relative to the provision of healthcare. As my lord knows, NSS Assure was created in 2021, following the concerns raised by both the Queen Elizabeth and the Royal Hospital for Sick Children and Young Persons in Edinburgh. In my submission, again, that may be an example of the ministers reacting in an appropriate way to issues which had arisen. I shan't rehearse the evidence, but my lord has heard detailed evidence from NSS Assure regarding what it does across a number of areas, a considerable number of areas, including rolling reviews of guidance and the collaborative nature of its engagement with health boards. My lord may also recollect the evidence about the KSAR process for building projects and the detailed workbooks which required to be completed at each and every stage going up to the final business case. And if my lord, as I'm sure he will, looks at those detailed workbooks, my lord may accede to my submission that the questions in the areas which are addressed and covered in those workbooks are very far removed from a simple tick box exercise. The workbooks in my submission ask probing questions over very many pages on very many issues, which the health board requires to address, answer, and vouch. And that KSR process, in my submission, provides a robust oversight of capital building projects and their procurement. And as this inquiry may recall, a health board will not be permitted to progress with a project if NSS Assure is not satisfied with the responses to the KSARs. My Lord, in my respectful submission, would be entitled to have confidence in the work of NSS Assure across all the areas falling within its remit. My Lord has heard detailed, careful and considered evidence from Ms Critchley and others. And my submission, my Lord, would be entitled to be place confidence and reliance on that body and its work. My Lord, turning briefly, if I may, again, on the topic of oversight of the delivery of healthcare in Scotland, on the question of HAI reporting, my Lord may care to note that the Scottish Government, Scottish ministers, have commissioned RHI Scotland to review Chapter 3 and Appendices 14 and 15 of the National Infection Prevention Control Manual. In the Healthcare Associated Infection Strategy of 23 to 25, the intention, my Lord, is that that should ensure, noting of course the submissions made by Ms Doherty shortly after lunch, but the intention is to ensure that there will be consistency in approach across NHS boards on the reporting of incidents or outbreaks of infection. And it is hoped that an updated outbreak reporting tool will be piloted this year. Finally, on the question of ongoing delivery of healthcare, mention has been made of an e-surveillance system, and my Lord has already heard evidence to this effect, but there is work ongoing currently to deliver and secure such a system.
Perhaps you might just give me that again. The ongoing work is?
To deliver and secure an e-surveillance system.
E-surveillance?
Yes. My Lord may recall that it was one of the recommendations by Council to the Inquiry, and I think supported by NSS Assure. And simply to advise my Lord that there is work ongoing relative to that.
The 3 chapters of the National Infection Prevention Control Manual, 14 and 15, is the third one chapter 3?
Chapter 3, yes, I'm sorry, my Lord.
Right.
Chapter 3 and appendices 14 and 15.
So, appendices.
Appendices,
right.
yes.
Yes, that's it.
Now, my Lord, having made those submissions, I go back to what I said at the outset, under reference to those submissions, to the effect that the ministers remain committed to the provision of the best possible patient-centred healthcare, and the existing arrangements to secure that are, in my respectful submission, in place. And one can see from a number, in short, from the areas briefly discussed by me, that how they operate in practice. But part of that commitment to the provision of the best possible patient-centred healthcare will, of course, be listening to the lessons to be learned from the output of this inquiry, to which, again, the ministers extend their thanks to the Chair, Council and the team. And my Lord, that concludes the submissions on behalf of the ministers, but I'm aware that my Lord may have questions for me.
No, I don't think I have. As I indicated, I was particularly interested in what you had to say about straying beyond involved matters, but I think that's the only matter that hadn't been otherwise addressed.
Thank you, my Lord. I was just checking if nothing arrived in my inbox to say I've missed out something, but there doesn't seem to be either on my part.
Right. Thank you very much, Ms. Croft.
Thank you, my Lord.
Well, I think we have heard from the parties scheduled for today.
Yes, Lord.
And looking at the timetable for tomorrow, I think we begin with Miss Watts on behalf of the three doctors.
Yes, indeed, followed by Miss Connolly on behalf of the Cudahy Mackay families, and then the afternoon, Mr. Love, responsible in respect to the larger patient and families group.
Well, thank you very much for attendance today, and I look forward to see you tomorrow morning at 10.
Yes, and